initiative on chronic kidney disease and management of hyperkalemia on World Kidney Day, organized by IHW Council, supported by AstraZeneca and Regency Health. World Kidney Day is a global health awareness campaign focusing on the importance of kidneys and reducing the frequency and impact of kidney disease and its associated health problems worldwide. The campaign has grown significantly since its inception in 2006, when 66 countries participated. By 2008, the number had risen to 88. The 2005 World Kidney Day is on 13th March with the campaign theme, Are Your Kidneys OK? Detect Early, Protect Kidney Health. It emphasizes the importance of early detection and intervention to prevent and manage kidney disease effectively. In India, approximately 10% of the population is affected by chronic kidney disease, and millions die each year because they do not have access to affordable treatment. This highlights a critical need for increased awareness and early detection to improve kidney health outcomes in the region. World Kidney Day serves as a pivotal platform to enhance global awareness about kidney health, encouraging early detection and preventive measures to combat the growing burden of kidney disease. It gives me great pleasure to welcome three accomplished nephrologists who will throw more light on how to recognize, manage, and treat chronic kidney disease. Please welcome Dr. Ranjan Sarkar, Senior Consultant Nephrologist, Manipal Hospital, Kolkata. Please also welcome Dr. Manisha Sahai, Professor and Head, Department of Nephrology, Osmania General Hospital at Osmania Medical College, Hyderabad. And please also welcome Dr. Kamal Shah, co-founder, NephroPlus. Thank you all for joining us this evening.
Thank you.
Thank you. I just wanted to make a small correction. I'm not a doctor. I'm not a nephrologist. I'm only a dialysis patient. Just wanted to point that out. Yeah. Thank you.
Sure. I wanted to give a brief introduction of all our experts joining us today. Dr. Ranjan Sarkar is a nephrologist with special interest in acute and chronic renal failure, hemodialysis, and critical care nephrology. Dr. Manisha Sahai's professional interests encompass diabetes, kidneys treatment and transplantation, and active contributor to medical literature. She has edited several nephrology books and serves as editor-in-chief of the Indian Journal of Transplantation. Mr. Kamal Shah has started NephroPlus, a patient-centric dialysis company that is now present in 5 countries with about 475 dialysis clinics, serving about 30,000 dialysis patients. So let's start this conversation, and I would like to start with you, Dr. Ranjan Sarkar. I want to understand, is this problem of chronic kidney disease increasing in our country? And what really is chronic kidney disease? Is it a disease you go to a doctor, take medicine, it gets fixed? Or is it like diabetes, something that will stay with you for a really long time, for perhaps the rest of your life, and it has to be managed with medicines, with insulin, or whatever management practice is best suited to the patient?
Good. I think it's a very good opening question. Chronic kidney disease is any dysfunction, structural or functional, in the kidneys, which is lasting for more than 3 months. So that's important, that the dysfunctional state has to be for more than 3 months. And it can be just a leakage of protein, a passing of blood in the urine, or the creatinine going up, which is a late stage of chronic kidney disease.
This problem of
chronic incidence is going up because the diseases which have the complication as kidney in their secondary or tertiary stages, those diseases are coming up, like diabetes, like hypertension, and there are other complicated autoimmune diseases which were previously getting treated, but the patients were not living long enough to have other complications. Now they are living long enough, like and also heart disease. So they are living long enough to have other organ damage due to their primary organ damage. The incidence of primary kidney disease, which is glomerulonephritis, I don't think the incidence of that is going up.
Mhm.
But there's diseases which affect the kidneys secondarily. These people are living longer, and that's why they are needing to come to the healthcare for looking for their treatment and management. And that's why the total number of kidney disease patients are going up every day.
So, Dr. Manisha, would you then say that if people manage their primary problem of, say, diabetes, hypertension, or the primary health condition, the risk for kidney disease would go down? Is it a linear progression? Is it a simple correlation? Or is this something you just can't help if you have another primary disease like hypertension or diabetes?
So I think, as Dr. Sarkar very beautifully explained, that there are many risk factors for kidney disease. Some of them can be modified, the others can't be modified. So for instance, if you have kidney disease because of diabetes, obviously you can control the diabetes and retard the progression of kidney disease. You know that the end stage of kidney disease is kidney failure. You come on dialysis or transplant. So it's very, very important that we try to prevent it or avoid it altogether. So for diabetes, it's called a modifiable risk factor. You can diagnose the kidney disease by certain tests in a diabetic patient and institute prevention measures early. They are called the golden rules. Some 10 golden rules by which you can protect your kidneys. Same thing applies if you have a kidney disease because of hypertension, because you can control your blood pressure. In India, what happens is the people start BP medications, and once the BP gets okay, they stop it. This is not correct. Once a hypertension patient, you may be needing the drugs lifelong and never stop the drugs without consultation with your doctor. So hypertension, again, you can modify it, control the kidney disease because of hypertension. The third important risk factor is obesity itself, which is growing nowadays. All of us are becoming overweight and obese, and that is definitely in your hands. With proper lifestyle modification, you can control this. You can reduce the risk of kidney failure in obesity. Now, other things are, for example, painkiller use. That's one of the common causes of kidney diseases in India. And can't you stop painkiller use? You can. In India, India is one of the countries where you just go to the market, purchase the painkiller over the counter. This doesn't happen in other countries. That's one of the commonest causes of kidney failure in our country. Then apart from these, you have some infections. For example, HIV. You have some rare diseases like SLE. So these diseases, again, I mean, you are bound to have those diseases. You have to take treatment, and maybe you may reduce the risk, not completely eliminate it. Then, for example, you may have genetic kidney disease. So there you cannot completely nullify the risk, but again, you can delay the dialysis or transplant. If you have a healthy lifestyle, if you control your blood sugar, control your blood pressure, and then perform daily regular exercise, get the tests done. It's very important to know that many of the kidney diseases in these conditions do not have any symptoms. You will be absolutely normal. Urine output would be fine. There won't be any swelling. The mistake happens is patients think that we don't have any symptoms. Why should we check our kidneys? Remember, in the Western world, everybody is checked for kidney function once in a year. In our country, at least the high-risk people, which Dr. Sarkar also mentioned, should be tested every year with a blood test and urine test and control the modifiable factors. So I would say 70% you can retard, 30% it's in your genes, but still, if you cannot avoid, you can still delay the progression.
All right. Dr. Ranjan, I'm still a little, flummoxed to understand why the incidence is going up. Dr. Manisha is saying that there are many diseases because of which, she enumerated to us and said that, because of patient not taking proper medicines, they don't even realize, they don't even know the symptoms. And it is an eye-opening thing for me that taking painkillers, which you talk so merrily if you have a fever or any niggling pain, we just pop it like this. I did not know it causes kidney disease. But if a patient is being managed for diabetes, is being managed for hypertension by a doctor, I would assume he would be tested for all of this to see that, everything is in control. So, why is it not picked up early, and why does it, then go on to become a chronic issue?
As Dr. Manisha just pointed out, that it's when the blood pressure gets controlled, people stop the medicine and they don't go back to check whether the blood pressure has gone up again. The same thing happens with any chronic health issues, and especially those which are not causing you any pain, any discomfort. So similarly, we don't check whether our sugar is normal, even if we don't have any other symptoms. If you cross the age of 25, I will say for Indians, it is imperative that you check the sugar at some point of time, every 2 to 3 years, if it is normal. And if it is borderline, then you need to check it every year. And when you start taking medicines, people go for a consultation, and then they keep on taking the medication for the next 3-5 years till they have another health issue. And if maybe it's because of an infection, maybe because of swelling in the legs, or some other complications when it appears they are not seeing very well, having difficulty in vision. And those things, when it impairs your daily life, then you come back to the doctor. Only a few percentage of patients in urban India, they are aware of the health issues. They go through these programs like today, and they will find that if you are diabetic, if you have hypertensive, if you have heart disease, if you have a family history of kidney disease in your first degree relations, then you need to keep an eye on your kidneys. You need to look for whether there is any problem. The earliest things that we can pick up from a urine test does not even need a needle in you. You don't need to even check your creatinine. It's the protein in the urine in the earliest stage, which is microalbumin, in the microalbumin stage. That's where we can probably reverse some of the patients to normalcy. And as the second part of your question, in the first question, was whether that disease will stay with you for the rest of your life. Yes, it will. Any complications from your primary disease will stay with you as long as the primary disease is staying with you. And also this glomerulonephritis or the immunological disease of the kidneys, they also, once your kidney is harmed, it keeps on harming itself. So it is a progressive disease. And that's why the earlier you start the treatment, the more you can delay the dialysis or kidney transplant, so you can prolong your kidney life. And if you can start there are statistical models to suggest that if you can start your treatment, full-fledged treatment for kidney disease when your creatinine is normal and it's just protein leaking from the urine, you can delay your dialysis even by 20 years. Now, if you can delay your dialysis by 20 years, then maybe you don't need the dialysis, and all of us will die someday or other. So maybe something else will take your life and not the dialysis, and you don't have to be on dialysis.
And this is why we need the awareness, because really, honestly, people don't talk about kidney health at all. People say, oh, India is going to become the diabetes capital in the world. Indians are becoming obese, everything else, but nobody's talking about how, kidneys or kidney failure is a problem. And, perhaps we spoke about it when a much loved union minister lost her life because of kidney failure. When we see celebrities or prominent people losing their life to something like this, we speak about it for a few days and then we get on with life. Kamalji, what is the biggest challenge you've faced in managing CKD? Because, like the doctors explained to us, these numbers are only going up because of, the primary disease incidence going up and these secondary, tertiary issues showing up. So what is the biggest challenge you have faced in managing CKD and how do you overcome them?
Yeah, so I've been on dialysis for 28 years now. I was diagnosed in 1997, and I've continuously been on dialysis for all these years. For me, the biggest challenge was, the fluid restriction. That was a big challenge because I was asked by my doctors to not drink more than 1 liter of all fluids put together. That included water, tea, coffee, curd, dal, everything that is liquid at room temperature. And drinking only 1 liter per day was very, very difficult. I think that was the biggest challenge that I faced. Apart from that, there were also other diet restrictions, like I couldn't have fruit, I could had less salt, I had to follow a bunch of other restrictions on milk and milk products and so on. Also, how I kind of overcame that the main problem of thirst due to low fluid intake and the diet restrictions was that I increased the number of hours of dialysis that I did every week. I made sure that I got enough hours of dialysis that would give me a good clearance and good time on the machine to basically pull out the excess fluid that had accumulated, even if it was a little more than what I was restricted. So that was one thing that I did that really helped and that improved my quality of life and energy levels and so on. Another problem that I faced was needles. In dialysis, there are these two thick needles that are inserted in the arm, so that was quite I was quite scared of those two needles, and I would tend to avoid dialysis sessions because of those two needles. But luckily, I found out about something called buttonhole needles, which are blunt needles and can reduce the pain significantly. So I switched to blunt needles, and that also reduced the pain associated with cannulation, the initial needle pricking at the time of dialysis. So I think these are the two main challenges that I faced, and that's how I overcame them.
Right. Dr. Manisha, chronic diseases are painful. You have to, weather them for a very long time. And Kamalji just told us what were the biggest challenges he has faced. Do you think there is a significant decrease in the quality of life for somebody who is diagnosed with chronic kidney problem? We are seeing Kamalji going on for many years with dialysis. How do you look at it as a doctor? You feel significant deterioration in quality of life, or do you think it can be managed? People can have regular lives, they can go to their work, they can have family life. It's all normal if you get the right treatment.
Absolutely. So I think till now in India, we were not focusing much on the quality of life because initially the dialysis itself was not available freely. Nowadays, you have dialysis at each and every district of India. So that's good. And many of the centers are providing dialysis free of cost as well for patients below poverty line. Erythropoietin is available, injection iron is available, and even the new dialysis material is disposable dialysis material is being given for every dialysis. So even the RO water, which is required for dialysis, is now available, which was not earlier available. So the quality of dialysis has significantly improved. And now, previously, we used to talk about numbers from doctor's point of view, looking at whether the creatinine is coming down after dialysis or urea number is coming down after dialysis. But now the treatment has become more patient-centered. See, what's the point of bringing down the creatinine and urea when the patient is not able to live a healthy, normal life? The purpose of dialysis should be providing an absolutely normal or near normal life to a dialysis patient. That should be the aim for dialysis, and that is the holistic attitude. So the patient should not feel restricted. The patient should be able to eat and drink whatever he has to with moderate restrictions. In addition, carry on with his work. If children, they should go about with their school life. If housewives, they should be able to perform their work at home. If working professionals, they should be able to go to their office or carry on with their business as usual. So I mean, the model should be like what Mr. Kamal is following. And I'm a big fan of Kamal. From the patient side, he is a big proponent of quality of life and doing a dialysis and staying well on dialysis and living well with dialysis. So that should be the motto, living well with dialysis. The patients should not feel that if they're on dialysis, they just go to the center, come back home, and that's it. And then await the next dialysis session and not do anything at home practically. That's what many of the people do. So I think there is need to increase awareness, have that positive attitude in the patients. We need to counsel them more, advise them on the proper diet, proper food restrictions, proper water restrictions. See, fruits, many people enjoy having fruits. We can't tell them no fruit for life. It is impractical. So they can have some fruits prior to dialysis. Even some juices may be allowed prior to dialysis. Chicken can be allowed, fish can be allowed, egg white can be allowed. So see, you have to tell you can take a practically normal, near normal diet. Many people stop dal completely. That is wrong. In fact, we should educate the technicians also that the patients who are on dialysis need a high protein diet. Please give a liberal intake of everything. Indian patients already take a protein deficient diet, so we should not restrict that further. So that's what we encourage the patients, that forget that you are on dialysis. Just go to the dialysis room. Think that 4 hours on you're on dialysis. You can watch TV, watch some movie on your cell phone, connect with other people, and do exercise on dialysis. Keep yourself engaged during dialysis, those 4 hours also, and then forget about it. So that should be the way of going for an in-center hemodialysis. The other type of dialysis can be done at home. That is peritoneal dialysis, which Mr. Kamal was on for, I think, half of his dialysis life. And that also can be done at home. So the thing is, as doctors, we need to talk to the patients a bit more. If you were in some of the Western countries, what they would do is they would have a team. In India, that team needs to be there, meaning a counselor should be there, a dietitian should be there, a nephrologist should be there. So this provides a holistic treatment to the patient. In India, what happens is the doctor-patient ratio is skewed, and every new member on the team means additional consultation for the patient. So all those issues are there, but I think a holistic approach is important. You need to spend time with the patient, explain everything, that dialysis does not mean the end of life. You should start living well with kidney disease. You should start living well on dialysis and start living well with transplant. Just think that it's an obstacle. It has been treated. You have overcome it and you're back to normal. That should be the attitude. That's what from my side. So quality of life, as you said, it should be
is what you make of it in the end, right?
Yes, absolutely. Just not treat the numbers. You have improved their blood. You have brought down their creatinine. That poison level has come down. But patient is just sitting on the bed and just not working, not living his life, not enjoying anything. I mean, that's not what the dialysis outcome should be.
Yes. But I think the best would be what Dr. Ranjan said, that, catch it early so that you will need dialysis 20 years later, and who knows, something's even better has come 20 years later. So, Dr. Manisha, can you tell us what are the new age or the latest advancements that have come in for early detection and diagnosis of chronic kidney disease? How do you catch it really early?
Okay, so my message to everybody who is on the call, including yourself and all other members, is that kidney disease in the early stages does not have symptoms. You will be perfectly normal. You may be a diabetic patient, good urine, no swelling, perfectly normal. You may be a hypertension patient, absolutely normal. So to catch it early, you should know that all of us may be at risk. As I said, in Western world, everybody is tested. Have you tested yourself? I'm sure you've not. Have
No,
I tested myself?
I test myself every 6 months.
That's good. That's good. So 6 months is
I
probably
had
overdoing it.
I had some frothy urine and I decided to go.
So that's good. So I take back my statement. But what I'm saying, even if you don't have any symptoms, you should test yourself. If that is not the case, at least the high risk group, diabetic, hypertensive, heart disease, family history, stone patients, painkillers, those patients should test themselves once in a year. And basic tests remain the same. You asked me about the advancements. See, the traditional tests, the urine albumin, which Dr. Sarkar already mentioned, and blood test, that is the creatinine. So that helps you calculate the percentage of your kidney function. To explain it to the patient, we calculate the GFR. What do you mean by GFR? Patient won't understand. So we tell them percentage of kidney function. So your kidney function should be 90, 100%. The GFR gives you that value, whether it's functioning 50% or 20% or 30%. The problem in India is patients come to us late when the kidney function is already down to 20% or 15%. Dr. Sarkar was telling you should pick it up early. Then it's even above 60% or 70%. And how can that happen? Even if you don't have symptoms, get the test done. Get a urine protein done, which is called albumin now, and get the creatinine done. Now, see, these are the old tests. What is required new is implementation. These tests should be done for all, even at the level of village, district, urban centers, everywhere. Now, some new tests have come. One test is called cystatin C. That costs around 1,200 rupees. Creatinine costs you 50 rupees. The urine albumin also costs you a few hundred rupees. The latest test, cystatin C, costs you around 1,200, 1,300. But the thing is, the answer to your question is, cystatin C is not mandatory. Get a urine albumin tested, get a creatinine tested, do it once in a year. If it's normal, repeat it once in a year. That's most important. Newer tests are available. Cystatin C is one of them. Now we have something called kidney failure risk equation. So if you calculate all those values and put it, you have an online calculator. Anybody can Google and check it. Put the values, you will know the risk of your kidney failure in, say, 5 years down the line, 10 years down the line.
These are the values that you get from a simple urine test.
Absolutely.
No needle being poked, simple urine test.
No,
and
that is only part of it. That is only part of it. You need, so Dr.
Blood
Sarkar
test
said
also.
the first test is without the needle poke. That is urine protein. You check the urine. The
Right.
second test involves a needle poke. That is creatinine. That's it. So these two tests are the tests which are mandated by guidelines anywhere in the world. So screening tests for kidneys are only two, not a battery of tests. You need not screen yourself every 6 months with a battery of tests. That's not required. That's waste of money, waste of blood. Once in a year, urine albumin and creatinine. Calculate your kidney score. That's called GFR. That's it.
All right. Dr. Ranjan, Dr. Manisha is saying patients come late. Why do patients come late? And why I'm asking you this question is because my friend's mother was diagnosed with kidney problem. Now, I was a little, I was a little, again, perplexed on why it came so late. She also said, perhaps the first thing they thought was, oh no, dialysis is the end of life, and it's a really bad diagnosis. So let's try some alternative medicine. Let's try something else. Let's try something else. By the time you try everything else, it becomes even more complicated. Do you think that is also another reason why patients come late? Because they're terrified of, oh, dialysis, it's a really bad thing that's going to happen to me.
Yeah, I think the fault lies with God. We should have had severe pain if we have proteinuria. And then all of us would have come to our doctor who has got protein in urine. It's because, as we are stressing, both of us, both the doctors here, that in early kidney disease, there is no discomfort in your lifestyle. There is no discomfort in your body. You don't feel any pain. You don't feel any shortness of breath, any chest pain. So for these minimal problems, patients will go to a doctor, get an ECG done, get an echocardiogram done, and all things to check whether the heart is okay. For kidney disease, there is no problem. So that's one major issue, that you don't have any physical discomfort even if you have a kidney problem. So there is inertia for testing whether I have got a kidney disease. Okay, I will do it next month. Okay, I will do it next month. Okay, I will do it next year. I am okay last time. Yeah, because there are no symptoms. And probably there is an inertia from the doctors as well. And I must say that the push the patient, if they are at risk kind of patients, diabetics, hypertensives, heart disease, first degree family, having kidney disease, any history of genetic disease in the family, then the doctor needs to push the patient for a kidney test as well. If it comes from a doctor, the compliance becomes much better compared to a friend telling you that are you a diabetic? Then you need to get your kidney tested. Now, you will obviously give much more weightage to a doctor telling you that this test needs to be done. But also, we are all busy in our life nowadays. And it's true that if you can carry on with your life without doing some things, those things get pushed in the background and you don't really they don't come on face of you. So unless the problem is really there, you are feeling short of breath because of extra fluid in your body. Your taste is not good. You are feeling nauseated. And that's the time when you think that, yes, I need to see a doctor. And then the creatinine is checked and the penny drops and we say the patient has come late.
Right. So it is, you just need to be more in tune, and the doctors also should advise their patients, especially those at risk, to be a little more proactive. Kamalji, what advice would you give to newly diagnosed CKD patients on handling the emotional and physical challenges? Because I remember my friend saying that, her mother, the biggest problem was the dietary changes, very low salt, and she would also then say, Mama, I will also have the food you're having. But her mom would not want to eat the food which is not nice. She started losing weight. Overall, her health really deteriorated. So, what advice would you give to those who are newly diagnosed with CKD?
I think obviously the ideal solution is obviously to prevent kidney disease in the first place. And if you've been diagnosed, like Dr. Sarkar and Dr. Sahai mentioned, delay progression as much as possible. But after doing all that, let's say finally somebody does land up in a state when they need dialysis, I would tell them not to lose hope at all. It is possible to lead a completely normal life despite being on dialysis. It is possible to lead a long life despite being on dialysis. I've been on dialysis for 28 years. I work full time. I swim every morning. I travel. I go out for a movie. I go out and have a meal with friends. I lead a completely normal life even today after 28 years on dialysis. So I believe that anybody on dialysis should not lose heart, should not lose hope. They can lead a life they were meant to. They can lead the life they want to. It is about being smart about it, about having a conversation with your doctor, telling them what your goals are from your treatment. Like some people, for them, work is very important. So you need to talk to your doctor and say, Doctor, I want to work 8 hours a day, 9 hours a day. You tell me how I can do that. And there are ways that can be done. Dialysis, I do my dialysis at night so that it doesn't interfere with my work. I do extended hours so that I can have a more relaxed fluid and diet restriction. So there are several things that can be done. It's about having a conversation with your nephrologist and talking to them and telling them that these are my goals, doctor. Please help me achieve them. Unfortunately, what happens is when somebody gets onto dialysis, because of the whole misconceptions that exist in society at large, that they just lose hope. They believe that their life as they know it has come to an end, and the rest of their life is going to be short, is going to be compromised, it's going to be very frustrating and depressing. The good news is that it does not have to be like that. There are hundreds and hundreds of dialysis patients around the world who are leading completely normal lives, who go on treks, who have run marathons, who lead companies. So dialysis does not mean the end of life. It means the beginning of a slightly different kind of life, but you can lead a very cheerful, productive, and long life.
There's no doubt that it does have a time commitment, because I saw my friend also getting overwhelmed. First, trying get her mom to eat, then taking her mom to the dialysis center. So, it does take somewhat of an emotional toll. But Kamalji, how does your organization help chronic kidney disease patients manage their condition better, especially in terms of dialysis innovation, lifestyle support? We want to give hope to people that first you find your disease quickly, early, be proactive. But if you do go down the road of chronic kidney disease, how is it getting better by the day?
Yeah, so at NephroPlus, we take that part of the journey of a dialysis patient very, very seriously. First of all, we provide very good quality of dialysis because that is the benchmark, that is the baseline above which everything else is built. Because if you don't get good quality dialysis, those 4 hours on the machine need to be, very good clearance you need to get. So that is the most important thing. That is the foundation on which everything else is built. We host the world's only dialysis Olympiad, where we call all the dialysis patients of the country to a stadium in a city, and we do this once every 2 years. And we And we hold Olympic-style games events for dialysis patients where they can compete against each other in disciplines like cricket, volleyball, basketball, table tennis, badminton, marathon, and so on. And at the end of the day, we give them gold, silver, and bronze medals. This goes to show that dialysis patients can take up a sport, they can exercise. So that is one thing. We also have an event called Ashaएं, which is held once every quarter, and patients are called to a location, and there's it's a whole day of fun and education where they are taught on how they can lead a normal life despite being on dialysis. And we also have a very popular holiday dialysis program because everybody likes to go on a holiday once in a while, right? But unfortunately, once somebody gets onto dialysis, they are worried about the quality of dialysis they will get in the destination dialysis center. So what we have done is we started a holiday dialysis program where anybody on dialysis, whether within or outside of NephroPlus, can get a very good quality dialysis, 2-3 dialysis sessions during their holiday, and they can enjoy a nice holiday with family or friends, and their dialysis is taken care of. That program is really popular and people love to go on a vacation. Many people have not gone for a holiday in years after getting onto dialysis, but when they get to know of the holiday dialysis program, they take advantage of it. And a lot of people have gone to Goa, Rishikesh, Kulu Manali, and various other places for a nice holiday despite being on dialysis.
But these are really heartening stories, and really goes to show that being diagnosed with kidney disease is not the end of the road. Dr. Ranjan, what are the key challenges in chronic kidney disease management in rural and underserved populations in India? Kamalji has given us an example of holiday dialysis, but in smaller places, much smaller than say holiday destinations. What's the situation like?
Very challenging. It's all about prioritizing your life. What are the priorities in your life? What's number one? So number one is that you'll have to have good square meals, 2 to 3 meals a day. So those are the things which comes in the underserved part of the country. I mean, when we talk about the Western world and the differences with India, in Western world, people don't like to stay in the cities. They like to stay in the countryside because they are close to the nature. They have got plenty of space. They're big bungalows with a big farm attached to the house, but they're only 5 minutes away from a ambulance service if there is a health emergency. And people who will attend them will be fully equipped for any kind of life support system which will make them safe to be transferred to the hospital. Now, if you think about the position or the situation that we have in India, it's and also in urban India, it's good to talk about dialysis and the quality of dialysis and all. But the first and foremost is the financial freedom. That what percentage of our patients of CKD can afford dialysis, even in a public-private partnership model in a government hospital. You will have to provide certain things, even in a government hospital. Certain medicines needs to be bought, and the food to have enough amount of protein, animal protein, we are talking about fish, chicken, egg, they are costly. So when we are talking about the issues in a rural setting or in a underprivileged society setting, it's a completely different ballgame. And that's why we come back to our primary discussion that even in that kind of scenario, it's best to treat them early. And it's best to catch them early and do as much as delaying of dialysis kind of treatment is possible. And that responsibility comes to the primary healthcare centers, unfortunately. And we are all urban doctors sitting in a tertiary healthcare center. Both me and Dr. Sahai, we are both in a tertiary healthcare center in a city, and we look after a different category of patients. Yes, some patients come from the villages. There are affordable patients in villages as well. but to them, the access to proper medicines, the access to the right kind of doctors is difficult. So like only today, I saw a patient who said that she is coming from 250 kilometers from Kolkata. I'm based in Kolkata. So when I said that you need to come back in a month, she said, "Can you make it 2 months, doctor?" Now that's where the compromise starts.
But then they are faced with loss of wages, the transportation cost, a lot of those things add up for these patients.
Fully agreed. Fully agreed. And sometimes the dialysis costs less than the ambulance cost.
Um, do we have enough centers for dialysis in rural areas? Can that become a possibility? Because, a lot is being achieved by technology, where, teleconsultation, early diagnosis, making the the primary care centers one which are more well equipped, and where the nurses there are more knowledgeable about these things. So would that be a good way forward, or would it a better idea would be to have affordable dialysis centers that have district level in states?
Well, to me, I think it's more important and less costly to educate the doctors to find out, to screen the population in villages, and screen the entire population that who have got diabetes and who doesn't. So to do that kind of an effort is much more rewarding compared to setting up a dialysis unit, because you can do teleconsultations. I can do teleconsultations for 5 districts, say. And so between all of us, all the nephrologists who are available in West Bengal, we can cover all the districts and all the dialysis units. But then you need a technician, as Mr. Kamal will vouch for, that the most crucial part of dialysis is the technician, or the dialysis nurse, or the dialysis care individual, as you call them. They can be a nurse, there can be a technician, or they can be taking both the roles as needed. So you need somebody who is true to his job and who will not go through any shortcuts, who will be adequately trained to handle certain things on his own, because teleconsulting, the doctor you're consulting over the phone or video call may not be available all the time.
So basically, that is our intention, to increase the awareness, to ensure that early testing becomes the norm in our country for kidney disease, for all other diseases. And that is our intention behind this initiative. Dr. Manisha, wanted to understand from you, what are the challenges of managing hyperkalemia as well, which I believe is a side effect of having kidney disease?
Okay, so before I answer that question, in addition to what Dr. Sarkar said to your previous question, see, we have to screen, we have to prevent. That is absolutely true. But those patients who have already gone into end-stage kidney disease, we have to take care of them as well. So you asked whether dialysis centers can be opened in all the districts. So you would be happy to know, and I would refer everybody to Google and check the Prime Minister National Dialysis Program. India has, in fact, it's one of the only countries in the world where you have dialysis centers in each and every district of the country.
Wow.
And so, I mean, we are way behind what are required, but it's such a healthy initiative. And in this public-private initiative, dialysis is being provided completely free of cost. I work in the state of Telangana, and you also mentioned about teleconsultation, hub and spoke. So I would also refer you to hub and spoke model. So we are sitting in the center, in the city, but our hospital takes care of 30 hospitals which have their own dialysis units completely free of cost. And the technicians there and the physicians there are also being trained at the hub center. And we have 24/7 telecommunication service and physical visits and ambulance services. So at the press of a button or a click of a button in my phone or pressing an icon, I can talk to a patient sitting 300 kilometers away on dialysis. Talk to him, talk to the technician. So that's, as you said, I think information technology is playing a huge role. We are only 2,500 nephrologists for 1.4 billion Indians. So I think technology is a tool which helps. It may not be ideal. It may not be as ideal as sitting and talking to your doctor face to face, but it definitely helps. So the quality is slowly improving. But as Dr. Sarkar said, we have to work both ends, prevent and treat those who have already progressed to end-stage kidney disease. And I think Kamal mentioned about holiday destinations and all. That's wonderful. But again, I also agree with Dr. Sarkar's point that there is a cost involved. And it becomes sometimes very difficult for people from the villages to get the basic facilities. So that becomes a problem, but it's good to know that these facilities are available. Now, coming to your question about hyperkalemia. So that is the major Achilles heel of patients who are having kidney disease, even those who go on dialysis. So hyperkalemia means increased levels of potassium in the blood. Now, where do we get this potassium from? Potassium is present in pretty much all the foodstuffs what we consume, and our kidneys remove the potassium. So high potassium causes irregularity of the heartbeat and may even cause death. So it's that important that the potassium levels should not be high. Now, there are some foods which are extremely rich in potassium. For example, banana. It's a very rich source of potassium. Coconut water. That's another very big rich source of potassium. Then coconut chutneys. Indians are very fond of eating all those chutneys and pickles, mango pickles. So all these are rich sources of potassium. So you have some low potassium stuff and you have high potassium stuff. And juices, people are very fond of juices, and they are very rich in potassium. So green leafy vegetables are rich in potassium. So you need to consume them for iron, but again, they have potassium as well. So hyperkalemia is an important challenge, and there are many methods to tackle this problem. First thing is by proper dietary advice. So you tell the patients which foods have high potassium, which have low potassium. We check their levels of potassium regularly. Some patients tend to have a higher potassium. Diabetic patients tend to have a higher potassium. Some people who have a good urine output, even on dialysis, their potassium levels tend to be okay. So there are other people who are on some medicines, painkillers, for instance, or there are other medicines, in fact, which are used for treatment of kidney problems and heart problems, which increase the level of potassium. So you can imagine some medicines which are being given for kidney problem, for heart problem, they themselves can cause a rise in potassium. So many antibiotics contain potassium. Many people are not aware, see which medicines contain potassium, which don't contain potassium. So there are many sources of potassium: diet, medicines, even the medicines which are being given to treat your kidney protein, your heart problem, they also contain potassium. So managing potassium is a challenge. Apart from diet, we have some medicines to manage the potassium as well. So there are medicines which can remove potassium from the body. You have other medicines which can be used short term. The major challenge is managing potassium long term with medicines, because we have a dearth of such medicines in India. So that would be a challenge. So definitely hyperkalemia is a very challenging problem. Diet alone sometimes may not be able to manage it. The good news is dialysis removes the potassium. But again, you cannot keep on advising dialysis for each and every single patient all the time. Even patients who are on thrice a week dialysis sometimes have a high level of potassium. So you cannot ask them to go on extended hours of dialysis day in and day out, 24/7. So you have to manage potassium by diet, by giving medicines which reduce the level of potassium, even in patients who are on dialysis. And you have certain drugs called potassium binders, which can be used long term. So I hope that clarifies some of your doubts regarding the hyperkalemia.
Dr. Ranjan, when it comes to hyperkalemia, ma'am has outlined for us, what it means, how it happens. Is there any way to prevent it, especially for those who are, diabetic or have hypertension, or maybe have early stage kidney disease? Can they be proactively managed to prevent hyperkalemia?
Hyperkalemia is not a problem of early stages of kidney disease.
Okay.
The kidneys handle different molecules in different ways. So the problem with the potassium handling starts after more than 50% of kidney damage has happened, and more or less around it starts to be a problem from more than 75% of kidney damage. So that's when the hyperkalemia becomes a clinically important thing. What Dr. Sahai has also pointed out to or alluded to is the drugs that we treat for kidney disease. They themselves cause hyperkalemia. And that's the challenge that we are looking at nowadays. That the potassium binders, the so-called potassium lowering drugs that we use now, have got lots of side effects, and they cannot be used on long term. So what we are now looking at is whether if we can continue the drugs which will prolong your kidney life and delay the dialysis, and at the same time we put the patients on these new generation potassium binders, which can be used on a long term, and so that will make those patients live longer life without dialysis. So we keep on giving the blood pressure medicines, we keep on giving the anti-protein medicines, and the medicines for heart failure, medicines for poorly functioning hearts, and these drugs also cause their potassium to go up. And because the potassium goes up, these patients cannot have those heart medicines as well. So it's not just for the kidney patients, it's also for the cardiac patients that sometimes they are off the medicines they need to be on. And that's because of the high potassium. So there are new generations potassium binders, which will be hopefully coming to India soon. And then we will be able to use our drugs. The cardiologists will be able to use their drugs and put the patients on these potassium binders for a longer term.
Right.
Quoting one of the American nephrologists in an ISN, he said that I use it like water.
Okay, let's hope all those options are available to Indian patients soon. Dr. Manisha, in your experience, what are the limitations of existing treatments?
So as Dr. Sarkar already alluded to, that the potassium binders which are existing nowadays, they can't be used long term. They cause a lot of disturbances in your gastrointestinal intestines and cirrhosis. So they are all serious problems. So apart from small problems, GI upsets and all, which are quite common. So we don't use them long term. So the thing is, if you are giving medicines for the protein leak, if you are giving medicines for the heart problems, which are common in kidney patients, then you have to use these drugs long term. And many of them cause high potassium levels. Now, with the drugs available to treat the hyperkalemia, the challenge is we can't use them long term. Whereas the other drugs, they need to be continued for life. So how do we manage the potassium? Diet is one thing I already explained. But again, you can't stop everything. Despite diet modifications, patients continue to have high potassium. We have to use the drugs to protect the heart, protect the kidneys. All of them raise the potassium level. So with the currently existing potassium binders, it's a big challenge. We cannot use them. We cannot use them orally. We cannot use them as enemas, because the problem of colonic necrosis is a major problem. You have ulcers in the bowel. You may have death of the intestinal cells, to put it in a simple language. So these drugs cannot be used long term. That's a major challenge with the potassium binders currently available in India. So we are all waiting for drugs which can be used, as Dr. Sarkar said, like water. I mean, that's what we also heard from our colleagues who are already using them. So you have a couple of molecules which are available. One of them we are hoping will come to India soon, so that we can continue treatment with cardioprotective and kidney protective medicines and use these potassium binders, which reduce the level of potassium along with these drugs. So that would make life easy for the patient or for us as well. Otherwise, we are very restricted in our treatment of high potassium. Dialysis is there. We can use some drugs called diuretics. We can use some drugs called sodium bicarbonate, but none of them, it can't be, I mean, just given forever to control the potassium levels. They have their own limitations. So I think as of now, in the current era, we do not have an ideal potassium binder in our country, and we are all eagerly awaiting for the newer potassium binders.
Right. Dr. Manisha, you have had experience in transplants as well. So would you like to say anything about that? Because, transplant comes with its own host of problems, finding a donor and, the body accepting it and, those issues as well. When does the need for a transplant come through?
Okay. So remember that transplant is the best option for a patient with kidney disease. So if transplant is not possible, then the patient settles for dialysis. So we should always keep that in mind. Transplant is the ultimate cure. Your life comes back to normal. So in India, we have 2 lakh people needing this sort of dialysis or kidney transplant every year, 2 lakhs. That's more than population of any country, right? In many countries. So 2 lakh people need dialysis or transplant. And how many is India doing per year? Between 15,000 to 20,000. That's it. So most of the transplants come from living donors. 90% of Indian transplant comes from living donors. Living donors means your parents or your siblings, even your children. Most of the times, spouses are your donors. Females, most of our donors are females. Around 80% of our donors are females, whereas around 80% of our recipients are males. So live transplants is one option. The other one is transplants coming from
organ donors.
Cases, brain dead donors. So that also is now taking organ donors. So that is also taking up in India. So you have both the transplants existing, but numbers, as I said, are still dismally low. We are doing only 20,000 for 2 lakh people. So the remaining people, they either have to go on dialysis, or if they can't afford that, or they can't get a dialysis slot, then again, they die a painful death. So dialysis is a poor replacement for transplant, right? So transplant, you said that is associated with problems. Yes, it is. But remember, problems, they amount to an insignificant percentage. 95% of the transplants really do well. Some transplants do not succeed. The major cause of transplant failure in India is infection. That's the number one cause. The second cause is a rejection. As you said, the body may not accept organ because of mismatch or some other issues. Then there is the third category where there are certain diseases where, because of the disease itself, the original disease itself, the transplant kidney fails because that original disease comes back in the transplant kidney. But overall, transplant gives a better quality of life. And keep in mind, 90 to 95% transplants do well, whether it is from a living donor or from a deceased donor. So transplant, again, you have to be on lifelong immunosuppression. You have to take those drugs for life. And these immunosuppression, as the name itself shows, it brings down the immunity. And once the immunity comes down, what happens is you are more prone to infections. And India is a tropical country, rich fauna, rich flora, everything grows. Even the microbes, bacteria, fungi also grow. And we have a lot of infections prevalent in our country. And that's the major number one challenge for our transplant patients. So again, you have to follow healthy lifestyle and protect yourself from infections, take proper vaccinations, don't stop your immunosuppression, and you can have a relatively normal life after transplant. The ladies get married, they can plan their family. We have so many patients who have come back to a normal life. See, because dialysis, what happens, all said and done, you have to go to the center and get it done, or you have to do it yourself at home. So it interferes with your life. It's not that you are completely independent of the machine, right? But transplant, again, the healthy kidney is in place. So the people getting the transplant have 3 kidneys. Their native kidneys are not removed. The third kidney is put. So the donor ends up with a single kidney. The transplant recipient has now 3 kidneys, and most of them do well. And transplant survivals also have improved in our country. So everything is not dismal about the transplant. Have that thought in your mind. A transplant could be a cure in around 90 to 95%. But again, everybody is not lucky enough to get a transplant.
Yes, and
sometimes the donors may not be fit.
And like you've
So donors may
discussed
not
the
be
numbers also, it's obviously not meeting the demand that we see on a yearly basis.
Absolutely.
So
Absolutely, absolutely.
I'll let Kamalji have the last word. We've spoken to the experts and they've told us, the expert doctors, nephrologists, that, early detection is the best to, stall the progress of chronic kidney disease. And like Dr. Manisha said, it's your mindset. You have to tell yourself that my life goes on. It's not the end of the road for me. What would you like to say to those who are watching this show? How should they take their kidney health in their hands?
Yeah, before that, I just want to make one small point to react to what Dr. Sahai just mentioned. I think in India, there's this very typical problem of gender disparity, right? And Dr. Manisha Sahai has written a whole paper on this whole disparity among men and women getting kidney
Yes, but she gave the
transplants.
example of girls going ahead and getting married. Then I was wondering
Yes, of
if the
course.
ones giving the kidneys away.
Those who are getting the transplants, but only, it's a 70-30 ratio. Dr. Manisha Sai wrote in her own paper, Men Are From Mars and Women Are From Venus was the title of her paper. So while the ratio between kidney failure, gender disparity is not at all 70-30, only 30% of women actually get kidney transplants compared to 70% of the men. So coming back to your question, I think like all of us agree, prevention is the best solution to kidney failure. The government needs to get involved in prevention. While the government has been doing a lot in the area of dialysis recently, thankfully so. And like you mentioned, after the two union ministers, passing away after kidney failure, I think the government needs to take prevention now very seriously, and prevention is much more financially also. Of course, it is much better for the patient, definitely no doubt about it. But even if you look at it from a cold numbers point of view, for the government and for the entire healthcare system, prevention is a much, much more cost-effective manner to deal with kidney disease than actually treating it once the kidney failure happens. Of course, we do need to take care of those who already reached kidney failure, like Dr. Sahai mentioned. Totally agree. But I'm saying that the government needs to do a lot in the area of prevention. And let's say, you weren't able to prevent it for whatever reason, negligence, lack of awareness, whatever. If at all you get to dialysis, don't lose hope, don't lose heart. Like I mentioned already, life can still be normal. You can lead a life that you were meant to, that you want to, and you can live for long, even after coming out of dialysis.
All right. Thank you so much, Dr. Ranjan, Dr. Sai, and Kamalji for joining us and talking to us about chronic kidney disease, how to catch it early, or the awareness that needs to be created. And thank you so much for creating the awareness by joining us on this show.
Thank you. Thank you so much.
Okay.
In conclusion, raising awareness about chronic kidney disease is crucial to prevent its silent progression and ensuring better health outcomes. On this World Kidney Day, let's commit to early detection, healthy lifestyle choices, and advocating for accessible kidney care. Together, we can protect kidney health and improve lives globally. Thank you all for joining us here and giving us your valuable time. Have a great evening and cheers to a healthy life.
Good night.
Good night. Thank you.
Thank you.
Happy World Kidney Day. Bye-bye.